Okay, hi everyone. Welcome to this episode of the Refrology series. And once again, we have Dr. Andre Tan back with us today. And today we'll be talking about hypercalcemia. So maybe we could just start with a very short case vignette of a 68-year-old gentleman with a previous history of rectal CA status post-surgery 5 years ago, and has been in remission previously. So he's currently admitted for generalized lethargy and some body aches, and was noted to have an adjusted calcium of 2.85. So we'll just loosely frame today's discussion around this case. So Dr. Andre, the first question that we have is, when do we need to do an ionized calcium over a normal corrected calcium?
Yeah, as with a lot of the kind of biochemical measurements that when we look at substances that are bound to proteins, there's always consideration of the free fraction. So same thing for calcium, because about half of total calcium is actually bound to albumin and proteins in the blood. So when we correct for calcium for albumin, is really to try and figure out what's the effective ionized calcium. So basically, measurement of the ionized calcium would be the most accurate measure of what the cells are being exposed to. But in most cases, you don't really need to measure the ionized calcium, since the corrected calcium or adjusted calcium is a good estimate for the ionized calcium. So it's really, by understanding this principle, you figure out that it is in states whereby you have changes in terms of the protein binding, or even fluctuations in the pH, because pH affects the degree of protein binding to calcium, that you may need to monitor ionized calcium. So a lot of times this is like in the ICU setting, and I mean in the ICU setting also, patients who are on the on CRRT, you know that you monitor ionized calcium rather than the total and adjusted calcium. And also if the patient has received multiple transfusions because of the citrate content that will bind to calcium, you would want to assess the ionized calcium. And then also for ESRF patients on dialysis. And ionized calcium is sent in the ABG syringe. So it's as per an ABG, you need to send it quickly and on ice to avoid the pH changes that will affect the binding to the proteins in the blood.
Okay, thank you very much. So the next question would be, what important points do we need to obtain in history? So let's say for this gentleman, apart from the bone pains as well as the body aches, what else do we need to hunt for in history?
Yeah, so we have this mnemonic that you all know from medical school days, the stones, bones, groans, moans, and psychiatric overtones, which drives home the point that the calcium, hypercalcemia affects multiple organ systems. So as per what you can see in the table, GI, renal, neuromuscular, skeletal, and cardiac. The most common symptom that we'll look out for is that of polyuria and polydipsia, because the high calcium actually affects the renal tubules and gives a nephrogenic DI kind of picture, because it affects the aquaporin 2 production. So these patients actually end up losing a lot of fluids, and when they lose fluids, then that affects the perfusion to the kidneys, and so the kidneys can't clear the calcium as well, and that results in a vicious cycle whereby they get more and more dehydrated, and that dehydration aggravates the hypercalcemia, which then causes more urine fluid loss from the renal tubules. So usually when they, if they are already quite significantly hypercalcemic, they will arrive quite dehydrated. And that's why when we manage them, we also need to consider a good amount of IV hydration to bring down the calcium. Yeah, I think the rest, like the body aches and all, can be non-specific. We also want to look out for the GI complications because of things like peptic ulcer disease and pancreatitis that can be associated with hypercalcemia. The renal complications of renal stone formation, impairment in the renal function. And then also like for cardiac and neuromuscular, you want to look at the ECG for any changes, and also for weakness. And very significantly, of course, if they're very hypercalcemic, they can have altered mental state. And then and of course for the bones, the development of osteoporosis and fragility fractures. Most of the time nowadays, we don't get the classic kind of presentation whereby the calcium is very high and they have multiple areas of bone involvement plus the renal stones and everything. which is like the full suite of all the manifestations. And a lot of patients with hypercalcemia are sort of incidentally picked up because of screening for other things, or
Yep.
like health screening or assessment for like chronic constipation, for example, or like memory issues or change in mental state. Yeah, so when we do find that as a biochemical finding, the high calcium should prompt us to look for other areas of organ involvement.
Okay, got it.
Yeah, then for the next
Yep.
slide is about the drug history. So obviously, in someone with high calcium, we want to look for drugs that may contribute or aggravate the problem. So lithium affects the calcium sensing receptor on the parathyroid glands, so it can affect the response of PTH to calcium and cause high PTH secretion despite a
Okay.
high calcium.
Yep.
And then thiazides actually affect the urinary calcium excretion, so there's reduced clearance of calcium from the body. But I mean, we use thiazides quite a fair bit, and most patients don't usually get high calcium. So it's usually if there's some combined pathology, like something else in the background, the thiazides make it like sort of unmask the hypercalcemia or make it more prominent.
Okay.
Calcium supplements also, again, rarely cause hypercalcemia unless there's something else going on in the background. But of course, we want to evaluate to see how much calcium supplements the patient is taking. And usually, if they are on calcium supplements and the degree of hypercalcemia is mild, we will stop the supplements first and then reassess without that. Yeah, I think the chronic use of antacids and excess intake of vitamin D and A are generally quite rare, but we will always screen to see what supplements the patients are taking.
Okay, will do. The next question is what initial tests should we be performing in the evaluation of hypercalcemia?
Yeah, so I think the most important thing is to look at the parathyroid hormone.
Okay.
The parathyroid hormone is really the main player in calcium homeostasis.
Yep.
And although you know that calcitonin also plays a role, but it is relatively minor. So we look at the PTH in relation to the calcium, and that helps us to divide it into whether it's PTH dependent hypercalcemia or independent hypercalcemia. And we want to do it in a fasting state because the intake of food can lower the PTH. So if you get a borderline or PTH that's not really high or low, then you may not be any wiser as to what's the cause. So it's best to get it in a fasting state.
Okay.
Yeah. So if the calcium is high, then normally what should happen is the PTH secretion should be suppressed. So any normal or high PTH would be inappropriate in that case. So that would lead us to think of PTH dependent hypercalcemia.
Yep.
And then we'll go on and evaluate the urinary calcium excretion, which I think it will come on to it later to differentiate between primary hyperparathyroidism versus FHH.
Okay.
And then if the PTH is low, then we'll look at the PTH independent causes, which then leads on to other investigations. So really the first cut is the PTH, and then the rest of the investigations will come from there.
Okay. In terms of the fasting duration pre taking the PTH, is there a duration that the patient needs to be fasted for?
Ideally, it's about 8 to 10 hours of fasting.
Okay.
Yeah.
And you also mentioned the previous slide about adjuncts of phosphate as well as vitamin D. I have a question about phosphate because we know that phosphate is often low if, let's say, the process is driven by PTH-mediated process. But how commonly do we see this? I mean, if, let's say, it's a PTH-mediated hypercalcemia, how frequently is the phosphate low versus it just being normal?
Well, I think it's related to the degree of hyperparathyroidism also,
Okay.
because your parathyroid hormone will increase the excretion of phosphate in the renal tubules. So most of the time, if there is hypercalcemia, there we will also see low phosphate if it's a PTH-driven cause.
Okay.
Interestingly, of course, if the underlying cause is because of high 125 hydroxy vitamin D, that will actually increase both calcium and phosphate absorption from the gut. So if you see a high calcium and high phosphate, then it's more likely due to the high 125D rather than a high parathyroid.
Okay, understand.
Yeah.
So the next question is basically what are the next tests, and you have alluded to them partially in your algorithm.
Yeah.
But I think so perhaps the first thing you can take us through is the urinary calcium creatinine ratio, when to do it and how do we interpret it.
So I think maybe if you go back to the
Yep.
previous slide where we look at the left side of the chart with the PTH dependent hypercalcemia, the two main differentials that we're looking at is primary hyperparathyroidism, and then the other is familial hypocalciuric hypercalcemia or FHH. And the main distinguishing factor between these two is that the urinary calcium excretion is low in FHH, but it is high in primary hyperparathyroidism. So by measuring the urinary calcium and creatinine, comparing it against the serum calcium and creatinine, we're able to get a ratio whereby mainly we are looking to see if it's low, and if it's low, then it might be more likely to be FHH. And then
Okay.
if it's not low, then we are more certain that it is primary hyperparathyroidism. Although sometimes, I think a lot of times in real practice, it may be difficult to really ascertain this clearly at the start, and we may do multiple urine measurements
Sure.
along the way to give us more confidence.
Okay.
And people ask about whether we do a spot urine or do a 24-hour urine collection. Of course, 24-hour urine collection is more accurate because we account for the diurnal variation in terms of the calcium excretion and so on.
Yep.
For convenience in the clinic setting, we usually do a spot urine, and if the spot urine is already high, then sort of we can be more certain that it's primary hyperparathyroid. And then if it's sort of low or borderline, then we'll do a 24-hour urine collection to be more confident about the results.
Okay.
Mm.
In instances where the PTH actually is very high and not just like within the like high normal kind of range,
Mm-hmm.
we still need to evaluate for FHH because I mean technically it's not a PTH driven process in this disorder. So in such instances, do we still check the urinary status?
Yeah, that's right. I think the clinical context is very important. I think if you look at primary hyperparathyroidism versus FHH, FHH is usually takes a more benign cause.
Mm.
The degree of hypercalcemia is usually not that high lah,
Sure.
and the degree of the high PTH also will not be so significant.
Yep.
And in terms of the prevalence as well, it is much rarer compared to primary hyperparathyroidism. So just by probability, is usually more likely to be PHPT than FHH.
Okay.
And also if with more significant symptoms and hypercalcemia, it's more likely to be PHPT as well.
Okay, understand. The next question is about the 125 hydroxyvitamin D. I understand that it is a test that can be sent off in the context of a low PTH, but I
Mm-hmm.
also understand that it is not cheap and it can take a while for it to come back. So
Yeah.
practically speaking,
Mm-hmm.
when do we decide to send it?
Yeah, I think we usually talk about the 125 hydroxyvitamin D and the PTH related peptide in the same setting,
Okay.
whereby we are looking at the evaluation of patients with PTH independent hypercalcemia.
Yep.
So uh, it, I think a lot of times it's sort of academic in that it helps us to figure out what's the underlying reason. But then, as in, even though we know the PTH-RP or the 125 hydroxyvitamin D, then we still need to figure out what's the reason for the elevated
Yep.
PTH-related peptide, which is most of the cases is malignancy associated,
Mm.
or the 125 hydroxyvitamin D, whether it's a granulomatous disease and what is the nature of that granulomatous disease,
Mm.
or is it like a malignancy-driven increase in production of the 125T?
Yep.
Yeah. So I think like for my flow chart, the main first thing is actually to assess for malignancy. So
Mm.
go back to the patient, get more history of are there any symptoms that will make you suspect any particular malignancy, and then do the necessary age-appropriate screening,
Yep.
imaging where you think is necessary as well. Yeah.
Okay. So are there any specific clinical instances where you find it useful in terms of how it might change your management or actually value add in clinical care to send the 125 and PTH related peptide? And maybe you can give us some practical things like like how long roughly it takes to come back for the results and like what's the rough cost profile of these tests if you happen to know it offhand?
Oh, okay. The two tests are sent to Mayo Clinic lah. So the turnaround time is about 1 to 2 weeks. It's not terribly long. And I think the utility really is maybe when you are looking at the treatment of such patients, then if it's a 125D driven process, then steroids can be helpful. Will help to reduce the production of 125D. Whereas
Okay.
for the other kinds of causes, it may not be so helpful. So there might be there will be an effect on how we manage the patients.
Okay, so like even if you establish like the patient may have granulomatous disease, but you're not fully sure whether it is necessarily driven by the 125
Mm-hmm.
process, then sometimes
Yeah,
having that information may guide your management in this regard.
yeah, that's right.
Okay,
Yeah, in terms of the cost, I'm not very sure the
sure.
exact price of the two tests,
Yep.
unfortunately.
Okay, no worries. Thank you. Okay, so the next question is what are the common malignancies associated with hypercalcemia?
So we understand that the main mechanisms driving high calcium in malignancy are of three different processes lah.
Yep.
The most common would be that of PTH-related peptide production by the cell. So it's like a paraneoplastic syndrome.
Mm,
It accounts for 80% of the high calcium, and
okay.
it is mostly from squamous cell carcinoma, so like
Okay.
SCC of the lung. I think there's a mnemonic of SCC being S for smoker, C for calcium being high, and C for clubbing. So high calcium is something that's associated with SCC of the lung. It can be SCC of the head and neck region as well. It can be seen in breast CA, renal CA, and so on. The other mechanism is when the cancer metastasizes the bone, and due to destruction of the bone and release of calcium, that actually leads to elevated serum calcium.
Okay.
So in that kind of case, you will look for metastases on a bone scan or a skeletal survey. And also multiple myeloma is one of the most common single type of malignancy that's associated with hypercalcemia
Okay.
due to the bone involvement.
Mm,
And then thirdly, in lymphomas, the cells actually increase the production of 125 hydroxyvitamin D. So that would drive the increased calcium and phosphate absorption from the gut and lead to a high calcium.
okay,
So these
got
are
it.
the three main things that we look out for.
Okay, thank you. The next question is what would be the subsequent workup when one is suspecting a primary hyperparathyroidism?
Okay, so I've divided that into sort of three categories. One is to firstly confirm the presence of primary hyperparathyroidism.
Yep.
Number one is that the PTH is a PTH-dependent hypercalcemia, and when you assess the urinary calcium excretion, it is not low.
Okay.
Then secondly, you need to localize the source of the excess PTH secretion. And most of the time it is due to like a PTH adenoma, either one single adenoma or multiple adenoma,
Okay.
or hyperplasia of one or more of the parathyroid glands. Very rarely a parathyroid carcinoma. And the localization involves imaging of the neck, either using an ultrasound or with a sestamibi scan to look at the parathyroid activity and uptake,
Okay.
or using a CT of the neck.
Sure.
Fortunately, each of the modalities has its own sensitivity and specificity, which is not very high in all of the cases. So usually we do two or more modalities to try and localize, because they
Okay.
may not have concordance. And it's mainly with a view to surgical intervention. Now, obviously, if we find a parathyroid adenoma, then it is amenable to excision, and that will settle the root cause of the primary hyperparathyroidism.
Yep.
And then also we want to assess for end organ complications, such as looking for renal stones. I think with an X-ray KUB, we can do a quick screen, and then also assess for osteoporosis. So
Okay.
BMD of the hip and lumbar spine.
Yep.
If there's suspicion of any like vertebral fractures, fragility fractures, you can do an X-ray of the spine as well.
Okay, got it.
Mm.
So then the next question would be after we have diagnosed primary hyperparathyroidism, how do we go on to manage and when do we consider surgery versus medical management?
Okay. Surgical management is really the first line treatment for a patient with primary hyperparathyroidism if you are confident in terms of the localization of the source of the parathyroid hormone. This criteria that I list here is really for asymptomatic hyperparathyroidism, whereby
Okay.
the calcium is not very high on presentation, and they do not have any other sort of end organ manifestations. So in those cases, then you follow them up, and then if they meet any of these criteria, so you propose surgical management. So
I
for
see.
the patients who are young, because they will require prolonged follow-up, and a lot of times during that process, they will eventually develop significant hypercalcemia or complications. So the younger patients, we would advocate surgical management early. And
Okay.
then if the calcium is significantly elevated to more than 2.8, or if they have skeletal or renal complications as listed there, then we would also push them for surgical management.
Okay. And
Mm.
the surgical management,
Mhm.
can I just check for my own interest, like if it's an adenoma on one side, is it then like just a removal of a hemiparathyroidectomy, or they remove the whole thing? How does it work in terms of deciding how much of the parathyroid to remove?
Oh, if it's a very obvious single adenoma, then they will just remove that adenoma. So
Okay.
it can be
Got
a
it.
focused parathyroidectomy, which would have a rather small scar.
Okay.
If they need to, if they're not, if the surgeon is not that sure that that is the only cause of the elevated parathyroid hormone secretion, then we need to do an exploration of all the parathyroids now. So then that
Okay.
will involve like a large scar akin to a total thyroidectomy, and then they will look behind the both thyroid lobes to identify all four parathyroids and so
I
on.
see.
And then
Okay.
sometimes there's ectopic parathyroids or parathyroids, additional parathyroid glands. So you have to do a lot more exploration. Yeah.
Okay.
So the importance of the imaging and localization prior to surgery.
Okay. Got it. And in terms of medical management, what does it entail?
Yeah, so medical management is if let's say the patient is not is relatively asymptomatic, or the degree of hypercalcemia is not very high. Like usually, a lot of times it's between like 2.6 to 2.7, and most patients with calcium of below 2.8, they tend not to have any symptoms. So
Okay.
we follow them up in the clinic and trend it, and we monitor the end organ complications like the bone, the renal function, and the formation of renal stones.
Yep.
And then in the meantime, we advocate for increased fluid intake. In terms of vitamin D replacement, usually if the calcium is relatively not severely high, they can receive vitamin D supplementation. So it's sort of a misconception that you shouldn't give vitamin D if the patient has hypercalcemia. But of course, if the patient is very acutely unwell in the initial setting when the calcium is more than 3 and all that, you want to give the necessary measures to bring down the calcium before you start them on vitamin D.
Mm.
But in the long term, by repeating vitamin D, you prevent that secondary hyperparathyroidism stimulus on the parathyroids to further proliferate and grow.
Yep.
So it helps to control the hypercalcemia to some extent,
Got it.
and then avoiding supplemental calcium.
Mm.
But for patients whereby they start to develop more significant hypercalcemia and complications, then we look at and they are unable to undergo surgery either because of like age, mobilities, or personal choice. Then medical options are either that of control of the hypercalcemia or treatment of like osteoporosis due to the hyperparathyroidism. So if you are mainly trying to control the calcium level, then Cinacalcet has a role there to block the PTH effects and bring down the calcium. But it's quite costly. I think it's about $10 per 25 milligram tablet, and sometimes you need to give up to 25 BD or 50 BD to
Okay.
control the calcium. And then if the main problem is that of the declining bone density, osteoporosis, fractures, then we can use anti-resorptives like IV zoledronate or oral bisphosphonates, or even denosumab. But these may not have much of an effect. One may have a relatively modest effect on hypercalcemia.
Okay. Thank you very much. Okay, so the next few questions are a few etiology specific
Mm-hmm.
related questions. So the first question is, does immobility really cause hypercalcemia, and how much immobility can we attribute hypercalcemia to?
Yeah, so I put this table there which shows all the possible causes of PTH dependent and independent hypercalcemia.
Yep.
And then immobilization is right at the bottom of the section on PTH independent hypercalcemia.
Okay.
It is rare and it's a diagnosis of exclusion. So I think we still need to do the necessary in going through all the possible causes of hypercalcemia before we call it immobilization associated hypercalcemia. And also the clinical context, like the degree of immobilization, how long they have been immobile for, and all that. I think in my experience, I've probably seen only 2 patients who had this, and they were both like very critically unwell, bedbound for a prolonged period of time, and so on. So we still have to make sure we are not missing out on another cause of hypercalcemia.
Yep, understand. And what's the mechanism? Is it known, or it's just something that we see associated with immobility?
It's postulated to be due to increased bone breakdown, the increased bone turnover and destruction in the immobilized patient.
Okay, got it. Thank you. So what about the endocrinopathies? This is a last-minute addition question, but when I was revising this topic, I saw hyperthyroidism, acromegaly, pheo, and adrenal insufficiency as listed causes of hypercalcemia. So how commonly do you see this? Should we be evaluating for these etiologies?
Okay, I answer the ones that are easy first.
Sure.
The pheochromocytoma is usually due to PTH-related peptide secretion.
Okay.
Adrenal insufficiency, I think we don't really know the mechanism by which it causes hypercalcemia.
Okay.
Hyperthyroidism is usually because of increased bone breakdown. So the hyperthyroidism can cause osteoporosis, and also, because of that, it will release more calcium into the bloodstream and cause hypercalcemia.
Okay.
Acromegaly, I'm not sure if it's associated with the hyperparathyroidism because it can, the main one may be associated. And of course, I think the increased growth hormone in itself can affect the bones and the calcium and all that.
But it's not that common amongst these disorders that it will cause hypercalcemia?
Yeah, that's right. Okay. Even if there is, usually it's to a modest degree, and just mildly elevated calcium, usually not moderate to severe.
Okay, got it. Okay, maybe we can just have a short discussion about familial hypocalciuric hypercalcemia. So perhaps you could take us through what is this condition. I think you've talked about roughly how to diagnose it, but beyond the urinary studies, is there anything else we should be doing? And do we have any specific treatments for this condition?
It is like I mentioned earlier, it is a relatively rare condition compared to primary hyperparathyroidism. Unfortunately, I think due to like the need to know it for exams and all that, it's always something that turns up when we look at patients with PTH-dependent hypercalcemia. It is essentially a genetic defect in the calcium sensing receptor. So the calcium sensing receptor sits on the parathyroid gland and then senses the circulating calcium. And if the calcium is low, then it stimulates more PTH secretion. If the calcium is high, it will reduce the amount of PTH secreted. But if there's a mutation in the calcium sensing receptor, it doesn't sense the calcium properly. So the set point for PTH secretion is shifted. And in that case, even though the calcium is elevated, there is still a degree of parathyroid hormone secretion that's inappropriate for the elevated calcium. Yeah, but when the calcium reaches high enough levels, then it will still be able to suppress the parathyroid hormone secretion. So usually in this condition, the patients have sort of a mild hypercalcemia, but they don't really develop moderate to severe hypercalcemia. They usually don't get any significant complications. Usually quite rare to develop like bone-related complications, for example, osteoporosis and so on. And because the calcium sensing receptor also is in the renal tubules and regulates the urinary calcium excretion, the calcium in the urine is low, so they don't get renal stones also. A lot of times we don't need to treat them specifically for this condition. Yeah, like I mentioned, because it's relatively benign and maybe we just need to monitor them longitudinally to check on the calcium trend to make sure that it's stable.
Okay.
Unfortunately, a lot of times they get misdiagnosed as having primary hyperparathyroidism and then undergo parathyroid surgery and all that.
Mm.
And then in the end, that doesn't change the condition. So
Okay, I
that
see.
might be
Mm.
more harm than good. Yeah.
Beyond the urinary studies, is there anything else that needs to be done to confirm this diagnosis or in the appropriate
Oh,
clinical
yeah.
context with, yeah,
Mm-hmm.
sorry,
You can
maybe
do
go ahead.
genetic testing
Okay,
to confirm the presence of the mutation in the calcium sensitive receptor gene. And there
okay,
are, I think, two other variants whereby it's like the G protein associated or another protein associated mutation that leads to FHH.
okay.
We'll ask them for family history. So if
Mm.
they already have a positive family history, it's an autosomal dominant
Mm.
transmitted condition. So usually
Okay,
you will see parents or
yep.
siblings having the same high calcium kind of
Mm.
picture.
Okay, so the gene testing normally will be done in instances where there isn't really a family history and you're not too sure about the diagnosis.
Yeah. I think we can
Okay,
consider doing that. But I think
sure.
in terms of the management, it probably doesn't change much,
Yep. Mm.
and it's more for like counseling about the uh, inheritance, passing on to the child, and so on.
Okay,
Yeah.
yep. Thank you. So maybe now we can shift gears a bit to the management of hypercalcemia in general. So I think most of us know that IV hydration is the main tenets of the management of hypercalcemia, but perhaps what we may not know so well is how much to give because we just know it's supposed to give a lot of fluid. So maybe you could give us some guidance on this.
Okay, I think usually the problem is not enough fluids.
Okay.
So I think like what the patients come in with is usually they are fairly fluid depleted, so they
Yep.
will require quite a lot of fluid resuscitation. I
Okay.
think it also depends on the degree of the hypercalcemia. So mild hypercalcemia is usually below 3. Usually those patients don't really need like IV, don't really need admission, but moderate
Okay.
hypercalcemia means between 3 to 3.5 and severe is above 3.5. Certainly
Okay.
if they fall in the calcium above 3, definitely will require IV hydration
Mm.
and admission to stabilize the calcium. So usually we give in this range like 2 to 6 liters of fluids over the first 24 hours. Usually the first 2 hours, you give like 1 liter, 2 liters to
Okay.
ensure that we sort of give them adequate perfusion. Because once we uh, have enough blood going through the renal tubules, then there will be increased calcium excretion, and that in itself will lower the calcium level already.
Mm.
So if you don't get enough hydration, then the calcium will not come down. Yeah.
Okay.
So and the endpoint that we look out for would be the urine output to try and
Oh.
maintain a decent amount of urine coming out at 100, 150 mils per hour if they don't have any renal impairment.
Mm.
And then we want to monitor the fluid status closely. Now, of course, if the patient has impaired cardiac or renal function or is a very elderly patient, then you want to be more judicious with the fluids and then reassess them frequently to see if you are giving enough or do we need to give a bit more and so
Okay.
on.
And,
And then because of the increased renal perfusion and all that, you might develop electrolyte abnormalities like hypokalemia and hypomagnesemia. So we must not forget to monitor these things and replace actively in such patients.
okay. And in terms of the crystalloid of choice, there isn't really a specific preference lah in the management of hypercalcemia.
No, yeah, it
Okay.
can be Hartmann's, it can be normal saline.
Okay.
Yeah.
Sure, will do. And then when do we consider giving loop diuretics? Because to some people it's a bit intuitive because you're giving, sorry, this
Mm.
unintuitive because you're giving fluids and you're giving diuretics at the same time. So when should we be considering loop diuretics and how does it work?
Okay, so the loop diuretic effect is number one to increase the tubular excretion of calcium,
Mm.
and number two, because when you keep giving fluids, then you run the risk of getting the patient into fluid overload, because you're
Okay.
already quite aggressively hydrating the patient. So that the loop diuretics also help to prevent development of fluid overload. So the
Okay.
role of the loop diuretics only come in really when you have given the patient quite a lot of fluids
Okay.
and you see that the patient is starting to get a bit, maybe showing some signs of fluid overload,
Okay.
and yet you still need to bring down the calcium further.
Mm.
Or if you are worried that if you cut down on the IV hydration, the hypercalcemia will get worse, then
Okay.
you add on diuretics there to sort of augment the effect of the hydration and further lower the calcium. So I
Okay.
think it's one of the few instances whereby you will give fluids and diuretics at the same
Yeah.
time, although it's quite
Yeah.
counterintuitive in most
Yeah.
other instances.
Yep.
Yeah.
And in terms of your dosing for the diuretics,
Mm-hmm.
how do you normally go about deciding how much to give? Mainly based on the fluid status kind of thing, is it?
Yeah, I think we will usually start with IV furosemide like 20 BD and
Okay.
then up titrate to 40 if necessary. I think because if it's a diuretic naive patient, usually with low doses they can already have quite a good effect in both fluid diuresis as well as calciuresis.
Okay. Thank you very much. So the next question is about calcitonin. So when do we give calcitonin? How do we give it? And for how long do we give it?
Okay. I think usually the first thing is hydration, and then after that you look at the calcium for the next 1 to 2 days. And if let's
Okay.
say it comes down very nicely, it sort of hits normal range or top normal, then you try to reduce the fluids and see how things go. But if
Okay.
let's say after some hydration, you think the patient has gotten quite a lot of fluids already, but the calcium is still sort of hung up, and all, then you would think of additional things like the calcitonin and the bisphosphonates to sort of give you a more sustained effect in controlling the calcium. And then
Okay.
calcitonin and bisphosphonates sort of like are complementary in that the calcitonin has a fast onset but doesn't last for very long because of tachyphylaxis,
Yep.
whereas the bisphosphonates have take a while to come in. When you give the bisphosphonate, it takes about 2 to 4 days before you see the effects of
Okay.
calcium lowering. Whereas the effect will be more sustained. So usually we give both at the same time. We start the calcitonin and the bisphosphonates together, and then for the first 2 days or so, the calcitonin will have a good effect in controlling the calcium. Then the bisphosphonates kick in a bit later.
Okay.
So this diagram is supposed to show the arrow being that you give the calcitonin and bisphosphonates together, and then that calcitonin fills in the first gap, the gap of the first few days, while the bisphosphonates come in at a later point in time.
Got it.
Yeah, and usually calcitonin, they say the tachyphylaxis will come in after 48 hours. So we usually give sort of 3 to 5 days of calcitonin sub-Q injections. And by after 5 days, probably there would not be much additional effect already.
Okay. So then maybe we could now talk about the anti-resorptive agents. So I understand that you can give either IV bisphosphonates or subcut denosumab. So maybe in terms of, is there a hypercalcemia level that you would consider giving these agents apart from just IV hydration therapy?
Yeah, so the similar what I mentioned earlier, it's usually for the moderate to severe
Okay.
hypercalcemia, like above 3, and then after I've given a bit of hydration, if it's still near to 3 or above 3, I would give both calcitonin and one of these agents.
Okay.
So the bisphosphonates wise, IV, I think initially you put zoledronic, but then we besides zoledronic acid, we also have IV pamidronate. So
Okay.
pamidronate is of course not as potent as zoledronic acid, and will have a shorter duration of effect.
Okay.
But probably the better thing about the pamidronate is if the renal function is a bit borderline, we may be able to get away with a low dose adjustment or running over a longer period of time.
Okay.
Whereas IV zoledronic acid is usually if the creatinine clearance is below 35, then I would be cautious in giving it.
Okay.
Yeah, and if really the renal function cannot make it and you can't use bisphosphonates, then you would consider using denosumab. Although I think
Okay.
denosumab is usually used more for hypercalcemia or malignancy.
Okay. Okay. And I understand that the dosing for the anti-resorptive agents are different from the way we dose in osteoporosis. So maybe you could share with us how we go about dosing the anti-resorptives in the context of hypercalcemia.
So for zoledronic acid, there are 2 formulations. One is the Zomita, which is 4 milligrams, and
Yep.
then Aclasta, which is 5 milligrams.
Yep.
The Aclasta 5 milligrams is what's been used in postmenopausal osteoporosis.
Yep.
So we almost, I don't think we don't usually use that for management of hypercalcemia. So if
Yep.
patient is hypercalcemic, we'll give the IV Zomita 4 milligrams.
Okay.
Yeah, infusion.
Mm.
Or the pamidronate 90 milligrams think over 4 hours.
Okay.
If let's say we need to dose adjust the pamidronate, we can give 60 or 30 and infuse over a longer period of time. But I think this one is not really, there's no clear guidelines to
Sure.
drive this type of dose adjustment. Or sometimes it's more like anecdotal or expert driven.
Yep. And the frequency of dosing, let's say this patient has persistent hypercalcemia, or let's say, do we tend to give more than a single dose, or it's normally used as a stopgap measure before more definitive treatment is being given?
I think we have to keep in mind that the effect of the IV bisphosphonates may not last more than like 8 to 12 weeks or so.
Okay.
Sometimes even if, I think pamidronate might be maybe even shorter. So if you're given it and then it's come down nicely for the next like 1 week, 2 weeks or so, the tendency is like, okay, you're quite happy with the result, and you might end up not catching it when it comes back up again. So there will be a rebound effect.
Yep.
So we have to keep monitoring the calcium, particularly at like 1 month, 2 month time points, to check for the rebound, and then think about redosing it again. I think if there is hypercalcemia, we can redose the IV Zometa or the pamidronate acid to control it. But of course, the long term, while we in the acute setting, we're using these agents to control the calcium, which buys us time to find out the etiology, and then the ideal treatment would be to tackle the etiological cause, the reason for the hypercalcemia. So long term wise, also, if possible, we try and treat the underlying cause, and then this repeat dosing is more of like treating the calcium, if it continues to be high.
Okay. And for the subcut denosumab, how do we go about dosing?
Yeah, so if it's like cancer related, they can use the denosumab up to 120 milligrams every like 4 weeks or so. So I think there is a role for using it more frequently and at higher dose than what we use for osteoporosis.
Okay, so if it is cancer-driven hypercalcemia, is denosumab routinely preferred over the IV bisphosphonates if, let's say, there's no renal concerns in hypercalcemia of malignancy? Yeah.
Yeah, I think it has shown positive outcomes in terms of the cancer malignancy-associated hypercalcemia in terms of the skeletal complications, which include, I think, hypercalcemia.
Okay, thank you. The next question is when are steroids indicated, and how do we go about dosing the steroids in this context?
So steroids will be in the context of elevated 125 hydroxy vitamin D production, which would only be because of granulomatous disease or like lymphoma. Yeah. So in those cases, then I think the regimen is more determined by the underlying reason for the disease and how you use steroids in those cases, rather than specifically. But I think in general, it's usually the 0.5 to 1 milligram per kg for prednisolone, or hydrocortisone like 200 to 300 milligrams, I think.
Okay,
in that kind of range, yeah.
Okay, and the final question would be, when do we consider dialysis for hypercalcemia?
Dialysis is really like when you have nothing else to throw at the patient to bring down the calcium already. It's really where it's very refractory to whatever else you can do. And of course, if the patient also has other reasons for dialysis, like other indications like hyperkalemia or significant uremia, renal impairment, and so on.
Yep. So I think we've come to the last question. I think this is a summary management slide
so
that you
basically
provided.
the summary slide.
So maybe at this point in time, while we wrap up, do you have any key take-home points for the listeners?
I think in terms of the workup is really PTH, parathyroid hormone assessment. When we want to find out the etiology of the hypercalcemia, and the degree of whether the patient needs inpatient management is really determined by the degree of hypercalcemia. Usually, if it's moderate to severe, and hydration is the mainstay for managing such patients.
Okay. So I got one last question, and this is a question about hypercalcemia of malignancy. So I think we have quite some of these patients who have sort of approached a sort of almost palliative point in terms of their overall care. But we know that they have quite bad hypercalcemia, and let's say they come in and then a dose of, let's say, denosumab is given, but at the same
Mhm.
time, when they get these flares of hypercalcemia, then they can be very symptomatic lah. So in these instances, how, based on your experience of what you've seen so far, how best would you advise in terms of like the follow-up care? Should we be still checking the calcium? Let's say the prognosis is not like going to pass on within the next 1 to 2 months, but maybe let's say a prognosis of slightly longer, maybe 4 to 6 months kind of ballpark figure. So how do you tend to follow up these patients?
I think that's a good question. I think the difficulty is in having, I guess, no real good measure to keep that calcium under control, because at the end of the day, if it's like metastatic
Yeah,
malignancy, then the underlying disease process is going to keep driving up the calcium. I think regardless of what you do,
yep.
and even the best measures may be few, it's sort of like may not really benefit the patient. But of course, I think we still try to bring it down to a degree where it causes the patient fewer symptoms now, because of the all the multiple organ systems
Yep.
that the high calcium will affect. I think if we keep it below 3, even if it's like 2.7, 2.8, 2.9, maybe it will help the patient to some degree. So I think maybe in terms of the maintenance, if possible, to increase to help to get the patient to take more fluids on a regular basis.
Okay.
Think about adding on a diuretic if it doesn't cause the patient to get more dehydrated.
Mm,
So
okay.
I think that always balancing out the benefit and risk of any treatment that we give. Yeah.
Understand.
Hmm.
Okay, I think that's all the questions I have. Thank you very much, Dr. Andre.
Okay.